If you want to know the biggest mistake you can be making with rehab programs, you need to tune into this episode before. Hi, everyone. Welcome back to the podcast. Welcome all new listeners and welcome back to those who have heard my content in the past. If you want to know the biggest mistake you can be making with rehab programs, you need to tune into this episode before I go into the podcast. What is new in life? For those of you who know, I've been enjoying trying to get more and more muscle ups. Recently, I tried, and it's like riding a bike. You don't forget it, but you kind of have to have a little tune up phase. So I'm struggling with my muscle ups again. I just finished week 3 of the Sports PT Kickstarter mentorship group. If you're in that, I love having you guys in there, and there's a lot of growth happening, and so it kind of goes into today's podcast. But what's happening with my kids? They still think dad is cool, so that's a big win for me. My daughter is slowly phasing out of that. She didn't want to give me a hug before she went to school, so I was like, oh, reality is kicking in at the age of 4. So that's what's happening with life. All right, onto this podcast. So, why am I doing this? So, all right, as part of my mentorship group, what I reviewed this recent week was how to create a really solid rehab program. For anybody, right? So any low back, knee, you gave me the region, you gave me the sport, doesn't really matter. They're all the same structure. And I presented a case that I'll present to you today, and a lot of people, probably 89%, said they were guilty of it. And I didn't realize that when you approach a specific way, you're going to put the athlete or the patient at risk. And we don't know what we know until we realize it. And so I'm going to show you some things today that really can help your professional development. And you really need to be paying attention to, is your rehab program as good as you think? So I brought it up because of the impact it had. I thought I'd share pieces of it with the rest of the world, and hopefully it can help you in your development as you manage your patients and athletes. All right, let's talk about it. All right. So does this sound familiar? All right. You have any patient or athlete comes into your world, right? Let's go non-operative, not post-op. Post-op is too easy. In your head, you can manage a post-op, but it's the non-operatives for some reason. The chronic insidious onset stuff that it just changes the way you approach an athlete, and it shouldn't. I'm going to prove that to you today. Does this sound familiar? You ready? You have a runner who has lateral knee pain, maybe IT band syndrome, right? And you evaluate them. You ask how many miles they run, how long has it been hurting, what have they tried, and you're waiting for like your moment where you're gonna be, oh, man, you're gonna be the movement expert. You're gonna figure out why this person has the IT band, and you're waiting for that knee valgus test, right? You're gonna do their running assessment. You're just like waiting. You're like, oh, they're probably that's it. They're gonna have it because they have poor movement quality and poor glute strength, poor core strength. Their knees all over the place, and that's the real reason why they have it. Sound familiar? Right? So you go to the test, you do a step down test or a single leg squat, or you see them running, and that's the real reason. That's it. So you create a program and you give them the impairments, and you're like, hey, listen, I know you've been having challenges with this, but ultimately you're having a knee pain because your poor movement mechanics. You have pain on the outside because it's putting pressure, blah blah blah, over time that develops weak strength and all sort of stuff. So it's just a cascade of events that led to why you have pain. So you create a plan and you're like, all right, week 1 you develop a program, knee valgus strengthening, whatever that means to you, right? And then you're like, oh, I'm going to work on their balance, their hips, everything else. Then you get their knee motion better, and then you get them stronger. Maybe they're a 4 plus, 5 out of 5. You get their hips strong, you get their core strong, their movement's better, and they're still having a little pain. So your movement like analysis didn't fix everything. So you're like, okay, so then you do some tissue work, you do all sort of stuff, and then you go to your corrective exercise and your Therex, and you're like, hey, we're still having challenges. So what do you do? Well, you're looking good, your movement's better, so let's add weight. Yeah, let's add some strengthening, more strengthening, get you stronger. So let's add weight to what you're doing. Okay, that looks good too. So let's add some reps. Okay, that's good. And let's add some intensity. Let's just make it a little bit faster and a little more challenging. Maybe a jump down or a hop down, right? So my point is, you saw an impairment, you fixed it, it got better. Now you need to like now you're trying to get them to the next level. So what do? You probably increase the number of exercises, you increase the intensity, you increase the challenge, you increase the load. You do all these things to try and like just keep pushing somebody, like until they run out of visits or until they tell you 100%. Is that usually like most orthopedic approach? They have an impairment, address the impairment, get them strong, keep challenging them until they have pain-free range of motion or pain-free activity. And I'm going to tell you right now, if that person asked you at the start of the initial evaluation, do you think I'll be able to run a marathon in 6 weeks pain-free? Would that have changed your response in your exercise? How would you have responded to that person? Or if they don't have a timeline, guess what? I think most PTs can get that knee pain better. If there's not a timeline, they're like, I just want to get rid of it. Guess what? You can take 6 weeks, you can take 12 weeks, you can take 18 weeks, whatever, whatever they are allowed to within, if they're insurance, if they're cash, whatever they want to do. But my point to this is, if that sounds familiar, you need to restructure your rehab process. Because ultimately, if you really want to be a sports physical therapist, you really want to be able to manage people at any given time, any timeline, maximize their outcomes, be the best version of yourself, get any athlete that comes your way better quickly, then you need to reframe this. And I'm going to show you a couple tips and clinical pearls that can change the way that you approach any initial evaluation and help you structure your rehab program. All right. All right. So there's something called resistance strength or resistance training pyramid, right? And in PT school, we learn this, and maybe you have your CSCS, you've read it all over the place. It's nothing new, but if you were to create a pyramid, at the bottom of that pyramid is the foundation to performance. Okay, so somebody wants to jump higher, faster, they want to run faster, they want to do it. There has to be a sequence of events that leads them to get faster. You ever had an athlete or a parent come to you and be like, hey, I want my son to run faster. I want him. So why aren't we doing sprint drills? Like, why aren't we doing the thing that like should be doing? Like, I want to jump higher. Why aren't we jumping in this rehab process? Why aren't we like, it's a strength phase, but why aren't we jumping all the time? Like, I thought, isn't that what gets them better? And you have to come back and educate the parent or the athlete. Like, listen, the foundation to power development is force. Force over time equals power. So I can't make them more powerful if I don't change the strength. So I need more force. So in order to develop force, that's going to take me time. It's going to take me 4 to 6 weeks at least for a neuromuscular standpoint just to get them engaged. And then it's going to take me another 4 to 6 weeks to get them strong. And then it's going to take me time to generate their power, that newly found power. So ultimately, you're trying to figure out there's a cascade of events that needs to happen to get somebody to sport. And the bottom, the base of the pyramid is neuromuscular control and balance. And that's what all PTs thrive in. We're like, if we are one thing in this planet of like in health and fitness, is we are like the neuromuscular control. Like we love control and balance. Take your time. Let's get proper movement. And the next phase after neuromuscular control is muscular endurance. This is like you've taught them how to move well. Now you have to stack a little bit of load or a little bit more reps to ensure that their tissue can handle the new stress over a longer period of time. So one was just introduce it at 8 to 10 reps, and then at muscular endurance, you're doing 12 to 15. And once they've been able to sustain that new amount of load or new amount of reps over time, now you know their tissue can handle it. Now their knee is not going to have a challenge with more than those reps per week or whatever you do. The next phase after that is hypertrophy. Now that they've built that endurance, let's actually build some strength on this. Actually, like get the muscle mass to develop, and that might take you 4 to 6 weeks. And then after hypertrophy is gaining strength, actual strength, not muscle size, actual strength, but you can't build strength unless you've had all the things down below. For somebody who's an experienced, athlete, they can move through pieces of the pyramid a little faster. But if you get somebody brand new who's never exercised before, who's never strength trained before, you're definitely going to have to take this at a slower pace. So once you've built that neuromuscular control, you've built that endurance, you've built that hypertrophy, you've got them strong, guess what? Now you can work on power. And the big thing that we worked on this week was, what is power? Power is force over time. So is the ladder drill a power or plyometric? It's force over time. Depends how you use it. Is a box jump force over time? Are you using it for, motion control? Are you using it for power development? Is a box, is a standing broad jump power? Absolutely. If you're using it for a measurement of distance. Now, if you're using it for, knee control and all those other things, but if you're actually using a plyometric movement where you have the stretch shortening cycle and it's power based, you can't improve plyometrics without having an increase in strength. If they're brand new to sport, of course you're going to fix it just from the novelty of a new task. But for some of you, this is brand new. For some of you, it's not. If you're in the strength conditioning world, this is a base level program on how do you get somebody stronger. I learned the foundation of this from strength conditioning coaches after I learned, okay, wait a minute. You use that in the weight room to get people stronger and more powerful and everything else. But wait, don't we as clinicians use that same framework in getting somebody post-op, ACL, all the way back to sport? Yes. So why aren't we using it for every non-operative, the same foundation? Somebody who's had knee pain, you got to back them down because they don't have the control, they don't have the strength. But what do we do as clinicians? That pyramid, every one of those levels requires time, 2 to 3 weeks apiece to get them out to where they need to be. But what do most orthopedic PTs do? They work on the neuromuscular control and they're like, oh, you got good movement. Let's just start doing some plyometrics now. Let's do some box jumps. That movement looks really good. Let's try some ladder drills. Let's do some single leg hops and all these other things. What you're doing is you're skipping significant pieces of that puzzle. And what that does is you never let that athlete gain exposure to the tissue tolerance. And what that does is it puts them at risk. So if you've ever had an athlete who, like you got the perfect squat, they no longer have that knee valgus, their hips are stronger than ever. And then you put plyometrics and their knee flares up. They're like, oh, you're just not ready yet. You're not ready. No, you failed as a clinician. You failed to set the pathway so that their tissues were ready to accept the load over time. You didn't build endurance, you didn't build the hypertrophy, you didn't build the strength, and you skipped significant steps and threw it onto power. Why? Because they had knee valgus. You cleaned that up. You didn't know what to do, so you started throwing more load. You started throwing more challenging exercises, more reps, more volume, and the person wasn't ready. And the reality is, your rehab process was not a process. It was let's just try it. Let me just see how it goes. So it's no wonder why a lot of orthopedic PTs become challenged with, I have to run this marathon in 10 weeks or 8 weeks or 6 weeks. Can you fix this in 6 weeks? People don't want to commit. One person on this mentorship group, they said, I said, why don't you guys commit? Like, what's the biggest fear? And only one person was bold enough to say they don't want to be wrong. So why don't PTs give a forecast of how long is this going to take me to get out of pain? Because we're fearful of being wrong. We don't know. First, some of us don't know. Second of all, we don't want to be wrong. And the reality is the patient or the athlete doesn't care. They just want to know, what is the probability of me getting better by this timeline, so I can either withdraw from the race, return the new shoes that I just bought. All they want to do is forecast. And just like as if, a patient or athlete went to a surgeon with knee pain and they're like, hey, I'm having, knee clicking, locking, and it's on the lateral aspect of my knee. The MRI said, I have a torn meniscus. If we do this cleanup, meniscectomy, what's the likelihood that I would be out of pain? And imagine the surgeon saying what a PT does. Well, let me just see how it goes. Let me just see you next week. Let me just see you in the ortho room and let me just clean that out. And we'll kind of figure that out. What's a person looking for? Confidence, certainty, so they can start planning. Because if they go to that surgeon, they're going to be like, that doesn't sound like really good probability. I'm going to find somebody else who can tell me that's going to be about 80% of your knee pain is going to be gone. I'll take that all day. 80%, I will take that all day. But the reality is that PTs, we don't think like that. We're hesitant to do that because we don't be wrong. Heaven forbid we're wrong. So what do? We just drag people along week by week. Let me just see how it goes. Next week, come in. Let me see if you're good. I know it's 6 weeks away, but let me just see how your mechanics look. That's really what's going to dictate. If your mechanics look good, maybe you'll be able to be closer to running that race, which is complete nonsense. How does cleaning up knee valgus 100% going to get them back to that point? Creating a foundation of better flexibility, strength, all those other things in a sequential order, allowing them to train on the back end and maintaining their fitness is going to give them a greater probability. One movement fault's not going to fix everything. And if it is, that's a 1%er. Great. All of you had one person get better miraculously through that one thing. That's great. What I'm saying is you need to have a comprehensive, better structure and approach to everything that you're doing from a rehab perspective. If you're doing this for a post-op, apply it to a non-op. That's all I'm saying. And guess what? A comprehensive program doesn't include just rehab. If you're going to take somebody out of running for 6 weeks, but their marathon is in 6 weeks, you better believe you better be working on their fitness, meaning energy system development, meaning if they're an aerobic-based athlete, but they can't run, you better figure out how you're going to get them aerobically trained to be able to maintain that fitness while they go through the rehab process. So meaning you're either in a pool, you're in a bike, you're swimming, you're in a rower, you're on a ski erg, you're maintaining their fitness. So why don't PTs do this? Because we're so obsessed with the movement and the knee pain and the little impairment. When you need to take a little bigger lens and figure out, wow, I'm pausing somebody for 6 weeks and hoping that my knee valgus is going to get them to run pain-free at a marathon. When in reality, that's one like 10% of the actual puzzle. You got to work on their endurance, get their hypertrophy going, get them strong, work on the ability to tolerate impact with that new mechanic, and maintain their fitness on the background. All while you're trying to choose the best exercise that's going to help them. The program is going to bring better structure than any single corrective exercise you can think of. And so I asked you at the beginning, does this sound familiar? Knee pain comes in, you look at the movement, you test their muscle strength, you look at their flexibility, you address all those impairments, and you hope by 6 weeks that they're going to be better. And you had no sequential order in how you're going to do all these things. I asked the group, I said, hey, if you have neuromuscular control, endurance, hypertrophy, strength, and power, all in the pyramid, how many of those phases can you overlap or simultaneously be addressing? And the answer is 2. You're probably working on neuromuscular control and hypertrophy with a little bit of overlap. And why? Because the nervous system. What happens to the nervous system when you're working on power development? It's trying to think of move fast, quickly, force over time, force over time, force over time. And what's happening on neuromuscular control? What's the nervous system doing? Oh, maintain stability. Don't mess up. Slow, calm, controlled. What are you working on with endurance? It's saying sustain this load over a longer period of time. What are you doing with hypertrophy? Build up the muscle bulk, the volume. What are you doing with strength? Get this thing off the ground, not as fast as you can, the highest amount of load in a very short time period. So when you're working on neuromuscular control, the nervous system is trying to process control. And if you're working on power, it's trying to get over, perform a task as fast as possible. So when you're overlapping, guess what most orthopedic PTs do. They do neuromuscular control, which is slow, steady nervous system. And then they're like, well, you're looking good, so let's just start trying plyometrics. So you add a fast movement. You're trying to add power with no base strength of no base of endurance, hypertrophy, or strength. Of course, your patients and athletes aren't getting better. It's because you're skipping steps, but it's not your fault. Now you know. And if you ask, okay, Chris, how long would you stay in each phase? Every single case is going to be a little different. Your timelines are going to be off. But in an ideal world, I mean, here's an easy answer. This is all science, right? So how long does it take for somebody, a novice, to build neuromuscular control just in like a strengthening phase? 4 to 6 weeks. So how long does it take for somebody to generate significant strength? 4 to 6 weeks. This is why in strength conditioning, the basis of strength conditioning is just science, just neuromuscular like adaptation. How long does it take for the nervous system to adapt, and then the tendons and everything else? 4 to 6 weeks. So let's just take 6 weeks for ease. That's why your post-ops go in 4 to 6 week blocks. You ever think about that? Let's get your range of motion. 6 weeks with a little bit of, base level of static strength. Then it's now from 6 to 12, we're going to get you strong. And from 12 to 18, now we start to load you with a little bit more impact. Guess that's why they're going in increments of 6 week blocks, because you're building neuromuscular control, you're building endurance, you're building hypertrophy, you're building strength, and you're building power. But when non-operatives, it's like the brain shuts off. And it's like, wait, you're not non-operative, so I'm not going to treat you like that. Let's just get good movement and then stack you with a lot of plyometrics right on top of that. Imagine doing that to a post-op ACL. 0 to 6 weeks range of motion and then sprinting them. Not possible. But yet we're doing that with non-operatives. This is just the irony of this. So it's a good wake-up call. If you're asking, hey, Chris, a lot of people ask me, what's a good CEU course to work on? Like, I really want to get better at knee pain. I really want to get better. The funny thing is, we're all looking for the best exercise, the next newest thing. When it's staring at you, provide good structure consistently and you'll get the best outcomes. No single exercise is going to solve this person's knee pain. It's not scraping, it's not cupping, it's not the twisty bandy rotational exercise. That's not what's going to cure this person. A solid foundation of incremental tissue adaptation with improved mechanics, with a base level of fitness and cross training right behind that, is going to get this person at an increased odds of going to this marathon with pain-free knee pain. So at the beginning of it, then you can say, listen, I know you have 6 weeks. We're going to go in 2 to 4 week blocks of each one of these phases with good mechanics. I'm going to have you work on swimming and rowing and, upper body erg or ski erg or something. That allows them to like, oh, well, actually, I have a plan. So what's the likelihood? If you work backwards, you're like, I can probably get you about 90% better by week 6. So that's like week 5 is 75%, week 4 is 50%, 25, 40%. And so they're like, oh, actually, I have targets to look forward to. So you want me stronger by week 4. I should be about 60% and 75 at week 5 and 90% by week 6. I can do that. And what does it do? It gives the patient or the athlete a plan or a focus point. And the reason why PTs don't do this is, one, we're not applying post-op phases into non-operative. And then number two, you don't want to be wrong. But what's worse than being wrong? Not giving an athlete direction, plan, and actual structure, or actually attempting and giving them an idea of what is possible. So what happens? The onus and responsibility becomes on the patient or the athlete, not you as a clinician. And that's the greatest fear. The irony of this, we don't want to be wrong, and we take all the responsibility. Or project, predict, allow people to have a plan, and put the onus on them. What does that do? Now the athlete is empowered, independent. Isn't that what we do as a profession? We like, oh, we want freedom from pain, give you independence. How are you giving freedom and independence when you can't even project and tell them how good they're going to be, because you're fearful of being wrong? So you're actually not giving them an independence. They're dependent on you coming back every week. Why? Because you can't give them structure. The irony of this whole thing is so funny. PTs always say, well, I want to make my patients independent. I want them to be able to manage their own pain. Sounds good. Give them predictions and give them things to work towards. They're like, oh, but I don't want to be wrong. So what are you doing? You're having them come back to you dependent on your information because you don't want to be wrong. Irony of the whole thing. I just find it fascinating. So, wherever you are, I hope that hits you. If you really want to work on facilitating independence and everything that our profession talks about, how about you give people a plan, confidently say, I can get you 92%, 87.6% better if you just follow this exact roadmap. But the reality is, we don't even know the roadmap. So you don't give them numbers. You don't facilitate independence. You have them come back just so you can't be wrong. I think that we are a dependent model in that fashion. So if you ask me where I got all this information, like how did I come to terms with all these things, I simply just took strength and conditioning principles, brought it over to acute injury management, brought over to orthopedic care, applied it to sports rehab, and it works amazingly. And all you have to, it's science, it's normal neurological, neuromuscular adaptation phases applied to normal orthopedic cases. So if you're looking to up your game, this hands down needs to be part of your structure. I hope this gives you like a solid golden nugget for wherever you are. If you want more, it's a little too late to join my Kickstarter program, but because of the requests and everything else, there's two things I want to say on that. Number one, if you're interested in the Kickstarter program, which was my mentorship group, I'm actually gonna, there's been so many people asking for it. I'm actually going to put it online so you can have a self-paced version of it. So that way you can continue to develop your skill set behind, even if you can't join me on the 8 weeks live, you'll still have access to all this stuff. So that'll come out soon. And then number two is consider taking my sports PT accelerator. Like if you're like, hey, Chris, I want acute injury management and return to sport, this is a perfect course for you. So everything I'm talking about right now from a structuring a rehab perspective, plus like acute injury management is going to be part of it. So if that's for you and you really want to no longer be a week by week person or a hope person or a saying you're independent, but you're no longer actually doing that, you're creating dependence on you and you're just because you're fearful of being wrong, you need to take this course. It is like the thing that will help give you so much more confidence going into that. So wherever you are, that's happening March 18th and 19th. It's a hybrid. We're doing both in person and virtual. It is a fantastic course. Head over to the website, drchrisgarcia.com/accelerator. If not, join me on my summit, join me on my Kickstarter, wherever you are. But ultimately, stop being like a week-to-week person who's claiming that they're a great PT and facilitate independence. No, you're not. No, you're not. And stop doing that. I think really you need to upgrade your program, look at a little bit more structure. And doesn't happen overnight. You really got to work on this. So wherever you are, I hope that helps. And I will see you on the next episode. Take care.